Good morning, everyone. So today we're going to be discussing STEMIs. I know it's super exciting, but try to rein it in because I don't want any of you guys to have a STEMI over it. I know, bad humor to start out. But since we're going to be talking about something pretty heavy, which heart attacks, myocardial infarctions, just try to use some levity to get it going. Why we're covering this today in class is because as EMS providers, you're often the very first link in the chain of survival for heart attack patients. Okay, the actions that we take in the very first minutes can drastically change patient outcomes. Okay, so we're going to focus on recognizing STEMIs quickly, providing right field management, and ensuring rapid transport to definitive care. This is just a quick overview of the agenda that we'll be covering today. Okay, we'll define what STEMI is, go over its basic pathophysiology. Then we'll also talk about recognizing STEMIs on the EKG. This is not going to be where we delve in depth in every single aspect of how we're identifying a STEMI on the EKG. Okay, we already covered that in our cardiology lessons. This is just a review so that we can once again make sure that we're seeing it and thinking about it in the way of field treatment. Okay, because recognizing it doesn't really do anything if we don't treat it in the field. So we're going to be covering the initial field management as well as the advanced care and transport. Okay, we'll just briefly go over a couple case studies, see if you guys are following along and have been paying attention. Just real quick, we'll look at some of the STEMI equivalents. Okay, little hint, most of them you should probably treat as a STEMI just in case. And then we'll just wrap up with some key takeaways and have some time for questions. Okay. So a STEMI, or as we call it in ST elevation myocardial infarction. It's amazing to think that we shorten to STEMI. Why do we do that? Yep, it's a mouthful. Okay. And this is the most serious type of heart attack. It happens when a coronary artery is completely occluded. Okay, this usually happens because of plaque rupture and then a thrombus forms. Okay, this is when blood can't reach the heart muscle. And that muscle tissue starts to die within minutes. Okay, that muscle ischemia that we're seeing actually on the EKGs, that is happening within minutes. Because if you think of it this way, every second of complete blockage, that heart muscle is starved of oxygen, okay? So after about 20 minutes, that damage actually starts to become irreversible, okay? So that is when we actually start to see the ischemia that is going to be permanent heart damage for that patient, okay? By 6 to 12 hours, you can lose entire sections of your myocardium though. Okay, so that is why we really try and encourage our patients to, if it's respiratory and cardiac, it's cardiac, please don't wait to call, okay? You don't want to wait to see if it passes. They need to call 911. They need to get this immediate treatment, this immediate assessment to see if they are having a myocardial infarction, okay? And so EMS is so important in this aspect because, like I said earlier, we're the first link in that chain of survival. The hospital can't save the muscle until the artery is open, and they can't open the artery until they know that's happening, until we've identified the MI and are bringing it to them. Okay? So here's a phrase that is really important to remember. Time is muscle. Because the faster that we identify, treat, and transport, then the more heart function we save, the less deficit that this patient that we're trying to treat is going to have moving forward in their, cardiac health. So think about it. An appropriate scene time for a suspected STEMI. Generally, most agencies will have their own protocols, and generally it will be 15 minutes as the maximum scene times they want you to have. Okay, that involves you showing up to the house, getting the patient, getting their symptoms, getting them assessed, getting them on that 12 lead, identifying the 12 lead and seeing, okay, I believe that a STEMI is happening here. Generally, like in my agency, we're told to get them on the 12 lead if they're having chest pain or similar symptoms within 5 minutes. Okay, then we're packaging them up and rolling. Right there, you're thinking, okay, why do we need the full 15? Believe it or not, there are still a lot of patients that are going to not want to go to the hospital with you. They either don't believe that they're having a STEMI, even though you're telling them that all signs are pointing to it, or they've already had them in the past and they don't think that this is probably it because it doesn't feel quite as bad or doesn't feel exactly the same. I actually had a guy recently that he ate chili early in the day and thought he was having indigestion because he'd already had 3 heart attacks. This didn't feel like that one. He had 12 stents already placed. Where he ended up was on my stretcher in the back of the ambulance going code 3 to Wake Med and brought directly up to the cath lab because he was having his 4th heart attack. Okay, and even then still had to convince him to go. So don't just think that you're telling them, hey, you're having a heart attack, makes sense for us to go to the hospital, that they're going to help you just rapidly meet that scene time. Okay, so when you arrive on scene, you have to think, what's maybe the first clue that we might be having a STEMI with our patient? So we have our classic presentations, of course, you know, the chest pain, the chest tightness, diaphoresis, you know, if they're sweating, a lot of times if they're feeling nauseated or if they've thrown up, especially if the pain is radiating anywhere up to the jaw, to the left shoulder, down to the left arm. Those are the classic, what we call classic presentations. But of course we can't stop there because there are a lot of STEMIs that present atypically or not as significantly as the patient or we may even expect. Okay, elderly patients, a lot of times they will complain of fatigue or confusion. Again, that's something that again is very common for elderly patients. So you might just write it off as being one of their typical complaints when actually that's being exacerbated because of the restriction of oxygen to their heart. Women may describe indigestion a lot of times or shortness of breath instead of pain. Okay, again, if you have a female patient particularly that is complaining of anything like that, you're going to want to go ahead and get an EKG just to see if there's anything else going on. We joke sometimes in the field that you can go to a woman with toe pain and she could be having a heart attack. Okay, go ahead and get an EKG if there's anything that might indicate something abnormal for the patient that would make you think, you know, hey, let's just see if it's cardiac. Okay, diabetics may also have silent or minimal symptoms because of their neuropathy. Okay, so they might not, because of how their nerves are reacting due to their diabetes, they may not be feeling the symptoms appropriately. So if we only rely on the classic textbook chest pain and other presentations, you're going to miss a lot of MIs. Okay, that's why the 12 lead EKG is so critical. Because the diagnostic hallmark of a STEMI is that ST elevation. It's in the name, okay? So we're looking for at least 1 millimeter of elevation in 2 or more contiguous leads, the leads that are associated with the same heart region. And we'll look at the regions of the heart shortly, okay? For example, if you see elevation in leads 2, 3, and AVF, you would then also look for depression in 1 and AVL, okay? So now we're also talking about our reciprocal changes, okay? As EMS providers, your job isn't just to run the 12 lead, okay? It's to interpret it quickly and use that information to make real-time decisions, okay? Every minute we wait for the hospital to call it is a minute lost. So we're going to want to take it. We're going to want to transmit to the hospital, yes, but we need to be making that determination ourselves and already moving down the treatment pathway even before we hear back from the hospital on whether or not they're going to activate the STEMI per se, okay? So here's an example. Like we've already gone over STEMIs in depth in our cardiology segment, but here is a pretty basic and pretty obvious example of an inferior STEMI. We do see the elevation here in 2, 3, and AVF. Pretty significant there. Now, if you glance over at 1 and AVL, that's where we're seeing those changes, those reciprocal changes in depression. So that's reciprocal change, and that confirms that this would be considered an inferior STEMI. Now, in most cases, an inferior STEMI is caused by an occlusion of the right coronary artery. It could also be the circumflex, but generally it's the RCA. We're going to review this a little bit more in our treatment, but inferior STEMIs oftentimes can involve the right ventricle. If it involves the right ventricle, we do not want to give nitroglycerin. Okay? Again, it's going to impact their blood pressure way more dangerously if they are already having ischemia in the right ventricle than it would for another patient. So we're always going to assess our patient before just giving nitro. Okay? Again, we'll talk about that more when we get to the actual field treatment. Here's a posterior STEMI. Okay, so at first glance, we're just seeing a bunch of, depression. We're seeing it there in V1, V2, V3, a little bit over there in V4 as well. So that depression in this case is actually the mirror image of the elevation that is happening on the posterior wall of the heart. Okay, because our leads are right there at the front of the heart. Okay, so they're taking, and the heart is kind of moved forward, so it's seeing those signs. It's not necessarily seeing here the back of the heart. Now, what we can do in this situation is take a posterior 12 lead. A lot of times people will also refer to that as a 15 lead. Okay, and how you do that is you take your leads, your 4, 5, and 6, and you take them and you move them around to the back of the patient and place it in those same locations, but on the back to get V7, 8, and 9. And that's how you're going to, some of the time, identify whether it is actually a posterior MI. Because then if you do that, you run a 15 lead, you run that posterior, and you see that elevation, okay, that's confirming it. There is research, though, that shows that a lot of times posterior 12 lead will only identify a posterior MI in about 25% of the times that you actually use one. Because again, the heart is tilting away from the back, so there's a lot more distance that the leads have to cover with the electricity to see what's going on in that heart, so it's not always going to capture that. So if you do a posterior and it does not show elevation, that does not mean in any way that they are absolutely 100% not having a posterior MI. If you still have that high degree of suspicion, you should treat it as such and still treat it as an MI. So here we're talking about the EKG lead territories. Okay, there's boxes here that align with each of the segments that we see on the EKG, 1, 2, 3, V1 through 6, and it's showing you what wall of the heart that it's basically showing you the electrical activity of that portion of the heart. You can also see in the pictures up there at top, the colors of the boxes below align with the colors highlighted on those particular areas of the heart. Okay, and those colors also help you identify the contiguous leads, which of the sections of the EKG are associated with the same section of the heart. Okay, you will see a note there that AVR doesn't have a color. It's non-diagnostic when it comes to a STEMI or anything like that, because there are no changes, electrical changes on the AVR for an MI. And of course, a lot of times we just looked at somewhere, we see some elevation in multiple areas, that it affects both V1, V2, V3, and V4. That right there, that's not just an anterior MI or a septal MI. That would be what we would call an anteroseptal MI. Okay, so when you're looking at an EKG, just think of it like mapping out which artery is blocked and thereby which part of the heart is at risk. Okay, so based off of that we just looked at, here are a couple STEMI region comparisons. Right here, we have an anterior STEMI. So right there, big ST elevation across V1 and V4. This also, as we just discussed, would be anteroseptal. It also involves the septal wall, but very much also on the anterior. So it's pretty significant there how you see that. Right here, we switch over to an inferior STEMI. Again, that 2, 3 AVF. You've got some pretty obvious elevation there. You're still able to see some of that reciprocal depression, but right now we're just mainly looking at the elevation and where it is on those lateral boxes. The inferior boxes right there. Sorry, I was doing the little L for loud, but the little L at the bottom of the boxes to show the inferior aspects of that STEMI. Lastly, here we have a lateral STEMI. We've got the changes there showing in the V5, V6, also we definitely have some in 1 and AVL. Those are all the lateral leads, very obvious, very significantly in the lateral region of the heart. Okay, now as EMS providers, we don't necessarily need to predict the exact artery with certainty, but we do want to recognize the pattern and get that patient moving as quickly as we can to definitive care, okay, and making sure that we're doing the appropriate care. So when we're talking about our appropriate care, our initial field management, a lot of times this is where small actions can make a huge difference. So we think about oxygen, okay? A lot of times, might be saying that they're short of breath or that they're having difficulty catching their breath. And so we think, okay, that's respiratory, we need to give them oxygen. But we need to once again assess the entire patient and what's going on. So if we hook them up and we see that they're having a STEMI, we don't necessarily want to put them on oxygen. We do if they're hypoxic. If their SpO2 is showing less than 90, yes, oxygen, of course. But if we give routine oxygen to non-hypoxic patients, that can actually cause coronary vasoconstriction, and that will then increase the oxidative stress on the patient's heart, which will worsen their outcomes. Okay, so a lot of times we need to treat the heart attack, go down the cardiac protocol, not just jump on the respiratory because they're having short of breath, because we don't want to cause any additional stress on their heart. So again, oxygenation only if they're what we would generally consider hypoxic under the 90% range. Now, aspirin. This is the #1 life-saving drug when it comes to STEMI. Okay, the chewable aspirin, 325 milligrams. We want to make sure that this is taken by the patient before we even get there. Dispatch, a lot of times, we'll try and get them to take that. If they haven't, it's the first thing we want to give them when we get on scene. Okay, this works by inhibiting platelet aggregation. So it's not opening up, it's not breaking the clot that is causing the MI, but it's going to stop the clot from growing and becoming more stressful against the artery and harder for the hospital to then fix and remove. So every EMS patient with a suspected STEMI should get it, unless, of course, they have the contraindications. If they are actually allergic to aspirin, obviously don't give it to them, or if they're experiencing an active GI bleed in addition to the STEMI that they have going on. Of course, aspirin can be life-saving, but we do not want to give it to a patient that it will then cause additional adverse effects. Okay, nitroglycerin. We've already kind of touched on this a little bit. It's great for relieving pain and that chest tightness that they're having. It reduces the myocardial oxygen demand by dilating the veins and the coronary arteries. But the catch is, if they're hypotensive, or if they had that right ventricular involvement that we discussed earlier, like with the inferior, that's very typical with the inferior MIs, nitro can actually cause profound hypotension, okay? Because what it's doing is it's reducing the preload in the heart. And if we're having a MI that is involving that right ventricle, it's relying so heavily on the preload to keep the heart working that if we reduce that, then we're actually making the heart having to work even harder, which is going to increase the amount of ischemia that is happening and at a faster rate. Okay. Also, we don't want to give nitro if they have had what in the past 24 to 48 hours? ED medications, right? Now, I will say, you're not just needing to ask men if they have had ED medications in the last 48 hours. There are some people that take this medication not just for erectile dysfunction, but actually to assist with their blood pressure because it can bring down your blood pressure. So you need to also be asking your female patients about this. Yes, it may feel a little silly to ask a female patient if they have taken erectile dysfunction medication, but you don't want to just assume that they haven't, give them nitro, and then here we are, we've absolutely tanked them, okay? For analgesia, for our pain management, pain relief does matter, and it can definitely, if we reduce their pain, it can reduce their anxiety, it can calm them down. Pain relief is definitely something to consider, but morphine and fentanyl can reduce the blood pressure. Morphine, much more than fentanyl can, but you still want to use caution when giving it, okay? You want to give it in lower doses, okay, to reserve it for significant discomfort, okay? If you've already given the nitro and that has helped relieve some of the chest discomfort and they're not concerned about the pain as much, then perhaps you don't need to go down the rate of further narcotic pain management, okay? But if the chest tightness is still there, or there's other pain that is radiating anywhere because of it, then yes, you can consider pain management. Now, a non-negotiable for this is continuous monitoring. Okay, the entire time that we have them in the back of our ambulance to when we get them to the hospital, they are on our monitor. We are doing serial 12 leads. That's taking 12 leads at least every 5 minutes, okay, because the heart can change, okay, as more damage occurs. The damage can spread. It can go to other areas of the heart. It can get worse. Sometimes, very strangely, it can also look like it goes away. That doesn't mean that they did not have heart attack, okay? But you want to be taking serial 12 leads and be able to show the progression, if there is a progression, to the hospital when you get there, okay? Because they can also develop lethal arrhythmias en route, as in VTAC or VFib, or even a complete heart block. And then, you know, we may not just be transporting a STEMI patient, we might be working a code in the back of our ambulance, okay? So, after reviewing just our basic kind of field management here, what is one thing that across the board we know that we want to do for a STEMI patient, for a suspected STEMI patient? Get a 12 lead, yes, that was obviously... So I shouldn't say obviously. Yes, that is the answer. What I was thinking of was the aspirin here, that we definitely want to give aspirin. But yes, absolutely, we need to make sure that if we're suspecting any sort of chest pain or cardiac issue, we want to do a 12 lead. Then when we have acknowledged that it's likely a STEMI, then what's the most important thing? The aspirin. Yes, thank you. You got me. So now we move to our more sort of advanced look of our care and transport. So we're going to want to have IV access, okay? This is particularly important if they start to go hypotensive. Even before you give nitro, you want to have IV access, IO, if you can't get it intravenously, okay? So even though like an EMT can give nitroglycerin to a patient if they have a prescription, you don't want your EMT giving them nitro before you have a line established, just in case, even if their blood pressure was fine and that they should be fine with nitro. It affects everyone differently, okay? So we want to make sure that we're getting that IV or IO access. Transmitting EKGs to the hospital is really important for really triggering that pre-activation of the cath lab. Okay. Now there are some times that we look at it and it looks like a STEMI to us. We transmit to the hospital and they say, we're not activating the cath lab. That's fine. We've done our part. We still take them to that hospital. We still do everything that we feel we need to do within our protocol. But a lot of times they might say, yeah, there's ischemia on that, but it actually looks a lot like, the last EKG he had. Okay. We may not know that. We may never have been to that patient before. Okay. So we don't know that that's normally what his EKG looks like because of his past 3 heart attacks per se. Okay. There are some agencies that are going to have, a heparin or antiplatelet protocol. Personally, my agency doesn't. And then, of course, we are thinking about our rapid transport. What's that thing I said earlier? Time is muscle. Okay? We want to limit our scene time, stabilize the patient, and transport rapidly. A lot of times, if you can patch them up and get them in the back of your ambulance, a lot of things you want to be doing en route. You don't want to be necessarily getting the IV access, doing the drugs and all that on scene. You can be doing that en route to a PCI-capable hospital, okay? So a couple just quick case studies, not really in-depth. If we think about so an inferior STEMI, I actually did this backwards. So I was going to say a 56-year-old male with chest pain. Yeah, an EKG shows inferior STEMI. So what is your treatment and transport plan going to be? Okay, so again, we've got our chest pain, we've done our EKG, we're seeing an inferior STEMI. If we go back to our field treatment, we're not saying anything about oxygenation, so we're not putting him on oxygen. We are going to go ahead and give him that aspirin. And then the next medication we would give is nitro, except right here we have that inferior STEMI. Right? So we would want to not do the nitro for an inferior just in case there's that right ventricular involvement. Okay, we would then follow the rest of the treatment plan, IV access, fluids if needed, pain management if needed, serial 12 leads, rapid transport to the hospital and the cath lab. Okay, so we then also, our case 2, an older woman with just vague complaints. She's just feeling malaise, basically, very tired, a little bit of weakness. We do an EKG and we're seeing ST depression in leads V1 and V3. So if we're looking at this and we're seeing this depression, like, okay, maybe it's a posterior. We should do something to check to see if this is a posterior. Do we remember what we discussed on how we would check that in the field, potentially? Posterior 12 lead, right. And the leads that we're taking to move that are 4, 5, and 6. That is correct. Okay, so again, that is what we would use to try and confirm that it's a posterior STEMI. It will not be perfect across the board, but it's just another tool in our toolbox to try and make sure that we're covering our bases. Okay. Now, if we're taking a patient and got STEMI and we're en route and now they're in cardiac arrest, they've gone into cardiac arrest, what would our sequence of actions be? Right. I didn't cover this earlier because we would cover it here. It is best practice if you have a patient that's experiencing a STEMI to go ahead and apply the pads to them, okay, your defib pads. Why? In case this happens, so that you can immediately go down the protocol and start CPR and defibrillation is needed, okay? Because like we said, a lot of times their heart attack can go into those arrhythmias, at VTAC, VFib. What are we doing for that? we're shocking it. Yes, a lot of times it may be okay to just have your pads handy, and that's fine as long as they're right there. You can slap them on if you're not trying to cause any additional concern or anxiety to your patient. That can be a consideration, but in these situations, if their heart attack then becomes a complete heart block or something else that leads to straight up cardiac arrest, you need to be ready to call full code response and work an actual cardiac arrest. Okay. Now we do have some STEMI equivalents. Okay, left bundle branch block. A lot of times with those wide QRSs and some abnormal ST segments, a lot of times a regular left bundle branch block can look like a STEMI, but it's just a left bundle branch block. That's why you have to use Scarbosa's criteria that we discuss in cardiology, especially using the concordant ST elevation or depression in that V1 through V3. Okay, so you have to keep that in mind. Again, even if they have a history of having a left bundle branch block and they tell you that, you still want to run down Scarbosa's criteria and make sure you're not overlooking anything there, because rather than just writing it off as a bundle branch block. So the De Winter T waves. So in this aspect, instead of seeing ST elevation, you would see upsloping ST depression and tall peaked T waves in the precordial leads. Okay, so this has to do with a proximal LAD occlusion. This is not a STEMI, but it is a STEMI equivalent, and it should be treated exactly like a STEMI. Okay, still rapid transport, give all the treatment of a STEMI. Okay, now if we have ST elevation and AVR with widespread depression, now if we put someone on an EKG and it's showing this kind of widespread depression across the way, that a lot of times can just be overall, they've generally had a history of, heart damage, and it's just kind of all over the place. They may not necessarily be having a STEMI in this instance. Now, if we're seeing widespread depression, but we are seeing that ST elevation in AVR, that specific pattern would suggest a left main coronary artery occlusion, okay, or what we call severe 3-vessel disease. This is rare. It's not something you're going to see very often, but it is extremely high risk and high mortality stats if it is overlooked. Okay, so again, if you just see overall widespread depression, don't just write it off. Continue to see what the signs and symptoms are on the patient, and then specifically you can look for that ST elevation in AVR. There's also Wellen syndrome. Now this is kind of a pre-infarction look, okay, for lack of better ways of saying it. This is characterized by deep symmetric T-wave inversions, okay, so abnormal, inverted T-waves in V2 and V3. This can even happen when the patient is pain-free. They don't have chest pain. That's not their complaint. But you put them on the monitor and you still see these T-wave inversions. Now, this could very well be indicating critical LAD stenosis, or what they call the widowmaker. So without intervention, these patients may very well progress to a massive anterior MI. Okay, so if you are seeing some of these indications that aren't necessarily saying STEMI, but it's indicating that ischemia is happening, okay, occlusion is happening, we still want to try and get them that rapid treatment, that rapid transport. Now, on the other hand, there are sometimes benign patterns that mimic STEMIs. There's benign early repolarization. That's pretty common in young, healthy patients. So generally, that's not where you see reciprocal changes in depression. Patient doesn't appear sick. They're not having a lot of other symptoms. Okay, so it's stable. Pericarditis is another one that can very much come across and look like a STEMI, but not actually be a STEMI. And then, of course, you are going to have patients that are complaining of chest pain. They're having difficulty breathing. They're nauseous. They're having the STEMI symptoms. You put them on an EKG, and it looks pretty normal. That's a lot of times what we call an NSTEMI, or a non-ST elevation myocardial infarction. Okay, these patients, they still need to be taken to the hospital and treated with a high degree of suspicion and as high acuity patients, because they're still having a myocardial infarction, very likely, if they're having, or they are if they're having an NSTEMI. But patients that are presenting like this may very well be having an NSTEMI, and that's determined by lab values, by getting them to the hospital, drawing up some blood work, and checking their troponin. Okay? In the back of our ambulance, we're not checking their troponin levels. Okay, so that's when I'll tell my patient, hey, based on how you're presenting and with your history, your cardiac history perhaps, I'm considering I have a high degree of suspicion that you might be having a STEMI, even though we're not seeing it on our monitor. So I'd like to get you to the hospital, get your blood work checked, and go from there. Okay? You still want to really encourage transport, even for those patients that aren't showing a STEMI on the EKG. Okay? So the bottom line is, if in doubt, treat it like a STEMI. Okay? Transmit the EKG. It's safer to activate a cath lab. It's safer to give the hospital heads up, to do rapid transport and all of this, than to miss a diagnosis and cause potentially undue harm for your patient. Okay, so just to summarize, again, early recognition and rapid intervention are absolutely critical. Okay, being able to hook them up to the EKG, get them connected, print it out, and be able to look with the knowledge that we've been covering both in cardiology and reviewing today. Hey, I think this is a STEMI. We need to start on our rapid intervention treatment. Okay, the EKG is that cornerstone diagnostic tool. Okay, you want to make sure on any patients that are having chest pain, chest tightness, anything like that, or even fatigue, nausea, difficulty breathing, respiratory patients, get an EKG. Okay, there could be a cardiac component that is affecting and causing these other symptoms, even if it's not directly chest pain. Okay, field management. Oxygen when needed, but not when not needed. Okay, what's that mark? About 90%. Okay, give them aspirin, 324 milligrams of aspirin, chewable aspirin. Make sure they're doing that. Nitroglycerin, if they're not hypotensive, have not had ED medications, or if they're having, if they're not showing to be having an inferior STEMI, then yes, you can give nitroglycerin, and pain control when appropriate. So oxygen only when needed, aspirin always unless contraindicated, nitro when it's safe to give, and pain control when it's appropriate. Okay, you're going to want to communicate with the receiving facility as early as you can. And when you're having patients that you're concerned of a STEMI, of these cardiac conditions, you very well are going to be bypassing. You may be bypassing the closest hospital because they're not PCI capable. You want to get these patients to the closest cath lab. Okay, so even if I always go to this hospital, no. You need to take them to the closest PCI capable hospital so that they can get them in the cath lab and get that clot out of there. Okay, and time is muscle. We want to minimize our delays. Again, 15-minute max on scene time for our STEMI patients. If you can get down less than that, even better. You don't necessarily want to say, oh, cool, we got them on the back of the truck in 5 minutes, so now I've got some time to do all of these other interventions. No, if you can do it en route, if you've got 15-20 minute en route time to the hospital, go ahead, have your partner head on, code 3, and do your interventions in the back of the truck. We really want to be minimizing those delays. The goal is to get reperfusion in our STEMI patients within 90 minutes from our first initial contact with the patient. Okay, so that's when we see them, when we first say, hi, my name is Heather, and we determine that they're having a STEMI, we want to get them to the nearest cath lab and get them the appropriate treatment, get them reperfused within 90 minutes. That's what we have found to have the best help of their mortality rate. Okay. Okay, mild snafu with the camera and recording, but that brings us to our very last slide, which is just if you have any questions or discussions. Okay, so just let me know if you've seen anything in the field already with you and your partner, or if you have anything that you've heard that's wonky. I know right now transmitting EKGs, sometimes people are like, oh, well, I transmit an EKG and then they never activated. That's fine. Like we said, we'd rather transmit and have it not be activated than to be missing something, perhaps. Any questions or anything? All right, if we have time, we can go over it later. Otherwise, I think you guys have earned a break. So thank you very much.